Welcome to This Explainer. Today, we're doing something, well, kind of unique. I'm stepping into the shoes, or I guess the clear plastic bag, of the most grabbed, yet deeply misunderstood IV fluid on your unit. Yep, I'm going to be telling my own story today.
Consider this my autobiography. To all you hardworking nurses out there, I am 0.9% normal saline. You know me, I'm the literal workhorse of the hospital. I save lives every single day, pumping up depleted blood volumes and fighting off dehydration. But we need to be totally honest with each other right out of the gate. I have a dark side, a dangerous one, and if you misuse me, I can cause some serious harm. So let's get properly acquainted, shall we?
Let's kick things off with my chemical blueprint. If you look really closely at my label, you'll see exactly what makes me, well, me. I pack exactly 154 milliequivalents per liter of sodium and exactly 154 of chloride. That's it. That's my core identity. Just a simple aqueous solution of electrolytes designed to perfectly mimic those essential ions already hanging out in your patient's body.
Now, when you add up that sodium and chloride, you get my next vital stat. A total osmolarity of exactly 308 milliosmoles per liter. And because that specific concentration is just so incredibly close to the normal osmolality of human blood plasma, I'm considered perfectly isotonic. That means I don't cause red blood cells to shrink down, and I definitely don't cause them to swell up and burst. I play super nice with the delicate balance of the bloodstream. But you know what's really fascinating? It's how I actually work once I get into that vein. Because I'm isotonic, when you squeeze a whole liter of me into a patient, I actually don't go into the cells at all. Nope, I stay entirely in the extracellular space to do my heavy lifting. Out of that 1 liter bag, I add about 275 milliliters straight into the intravascular plasma volume to really pump up that blood pressure, while the rest just kind of shifts into the interstitial space. Honestly, I'm the ultimate volume expander.
All right, let's look at my resume and when you should actually call me in.
If your patient is crashing hard from severe dehydration, massive hypovolemia, rapid hemorrhage, or even septic shock, you need to hang me on that pole immediately because I go straight into the circulatory system. I have an instant onset. I completely bypass the GI tract, which means I go to work right away, replacing that extracellular fluid and restoring hemodynamic stability. Plus, I'm the absolute go-to choice if you're dealing with metabolic alkalosis alongside fluid loss, or if you just need to correct some mild sodium depletion. Ooh, and I absolutely cannot forget my most exclusive credential. I am the ultimate blood wingman. Seriously, I am the literally only IV solution you should ever trust to run alongside a blood transfusion. Other fluids, they can cause hemolysis or some really dangerous complications. But me, I'm perfectly formulated to safely prime those lines and smoothly escort packed red blood cells right into your patient. So with a resume like that, you're probably thinking I'm just this flawless miracle fluid, right? But let me ask you a serious question before you go hang in my bag for every single patient on the ward. Am I perfect? Well, that brings us to the dark side, my hidden risks. It's confession time. Because underneath this clear, innocent appearance, I carry some pretty heavy clinical baggage. I'm not just harmless saltwater, guys. If you aren't paying close attention, I can flip from a hero to a major hazard real quick. Remember those 154 milliequivalents of chloride we talked about earlier? Well, if you infuse me too fast or in massive volumes, that heavy chloride load can cause problems. Combine that with the fact that my pH is actually slightly acidic, sitting somewhere between 4.5 and 7, and we can trigger a very real, very severe complication. It's called hyperchloremic metabolic acidosis. And here's exactly how that danger builds up. When I flood the bloodstream with all that excess chloride, it forces bicarbonate ions to shift intracellularly just to try and maintain equilibrium. This dramatically drops the blood's buffering capacity. And because of this metabolic acidosis, you might see a really dangerous shift where serum potassium is forcefully pushed straight out of the cells and into the extracellular space. This causes a highly dangerous spike in your patient's potassium levels. Not good. Also, because I so aggressively expand fluid volume and hold on to sodium, I am absolutely the worst choice for patients who are already struggling with fluid retention. If your patient has heart failure, pulmonary edema, or failing kidneys, please do not use me. Adding me to their system is literally like pouring water into a bucket that's already overflowing. You're just going to trigger circulatory overload and severely compromise their breathing. So, let's open up the manual on how to handle me safely. How do we actually work together without causing harm?
To harness my benefits, you've got to stick to my strict handling rules. Because remember, once you push me into that vein, you can't take me back.
Okay, before you even think about uncapping my tubing, you've got to establish a baseline. Document those vital signs, check their edema status, and grab a baseline weight. Once I'm actually infusing, you're officially my supervisor. Keep a stethoscope handy to continuously monitor those lung and heart sounds, and keep your eyes glued to that urine output. We really want to see greater than 0.5 milliliters per kilogram per hour, just to know those kidneys are safely handling the volume. Oh, and you'll definitely want to check a daily serum metabolic panel to keep a close eye on those sodium, potassium, and chloride levels.
You also have to be hypervigilant for my red flags. If you hear new crackles down in the bases of the lungs, or if you feel a bounding, rapid pulse, or hey, if you look over and see their jugular vein popping out, you've pushed me way too far into fluid volume overload. Other big warning signs include sudden hypertension, shortness of breath, and peripheral edema creeping up from the feet and ankles. If you see any of this, you need to act fast. Elevate the head of the bed, elevate their legs to help venous return, and notify the provider immediately. They might just need to order a diuretic to help clear me out. Look, I'm an incredibly powerful tool in your nursing arsenal, and I am so proud of the lives I help save every single day. But I demand respect. I need your close monitoring and your keen clinical judgment. So I'm going to leave you with this final thought to ponder. The very next time you unwrap my bag and hang me up on that IV pole, ask yourself, are you wielding me as a lifesaver or a liability?